what we have here is we have a examination for dysfunctional scapular movement. So one of the things we can do first is we can do a full abduction of the shoulder complex, shoulder cap. So what we'll have our patient do is bring his arms straight up above his head with his palms facing outward. Yep. And back down. And one more time. We have a hold it. What we're looking for is the scapula to move in a smooth motion without any catching or clicking or winging. We ask our patient, does he have any pain or discomfort with that?
No.
If they did have pain or discomfort with it, you can ask your patient to go through one side at a time. So we'll do this right side, and what you would do is you would mobilize the scapula as it went through the range of motion, so back down. So depending on the pain, as they're raised, you would move it into external rotation, or you can move it into posterior tilt. Just the scapula, I'm just pushing on the scapula as them go through the range of motion again. Anterior tilt to the range of motion. Scapular depression. And scapular protraction. And see if any of those assistant movements help with the pain. Once you diagnose that, you prescribe the appropriate exercise rehabilitative protocols for that. Another test we can do is the shoulder flexion test. So patient just flexes the arms straight up above them, in front of them. And again, we're looking for proper scapular movement, which would be an external rotation, posterior tilt, and depression of the scapula, which he has, but you can see some abnormalities, discrepancies, and range of motion between the left and right. So we have our patient go back down. Another assessment we can do is a wall push-up. So we have our patient here and have them do a push-up on the wall. You can bring their legs a little closer, a little closer. There you go. What we'll be looking for is scapular winging, so that lifting up off the thoracic rib cage, right, which he does not have. That would be indicative of like a long thoracic nerve damage. Have a patient do it again. We're looking for up and back up. And finally, once we go through those things, we can have our patients do a few rehabilitative things. So the first thing we have right here is we would do passive care. We can do something like manual mobilization as they were laying down, where we go through and we mobilize this scapula through all the ranges of motion, similar to what we did with that active test, but just while the patient is laying down, we passively do it. Secondly, we do soft tissue mobilization, massage, Graston. We can also use E-stem to try to loosen any hypertonic muscles or weak muscles. So if, for instance, if the levator scap was overactive and preventing the scapula from depressing, we might want to put an E-stem onto the levator scap to one, pain modulation if they have pain, but two, you can use it also to fatigue the muscle. That will allow the mid and lower trapezius to activate and depress the scapula. So now we can go into static range of motion, static rehabilitation. So I have my patient do a wall push-up again, but this time I want their chest up, head up, and I want them to roll their shoulders forward, try to pull the scapula apart, hold. We will hold this for 20 to 30 seconds for 2 reps, right? And relax. And then we can have retraction on the wall. So bring the scapula together and hold for the same amount of time, 20 to 30 seconds. From here, we can also do the active stability, which is have them go through that motion consecutively. So down and up, Just the protraction, retraction, and retract, and protract. And we can have them do that for 3 sets of 10 would be ideal. 3 sets at 8 to 10 would be ideal. From there, we can also go into, so this will work retraction, protraction, or retraction. We can also have them do wall angels. So patients up against the wall facing the camera. Feet out from the wall, back flat up against the wall, upper body flat up against the wall, head back. Have them going through full range of the motion with the hands elevating, palms up against the walls, high up as they can, and back down. And we can also have them do just a straight press. So we would have them here, have the patient bring the arm straight up and back down, straight up, back, up, and back down. So as you can see, we have a patient here is unable to complete that motion. That can be indicative of something like a restrictive lats. It can also be tight restrictive thoracic spine. We can do strengthening now. We have our patient do Y's, stand on the band. So I'll demonstrate for our patient, stand on the band and pull up into a Y and back down. You can use one foot as well to make it easier. And back down. You can face the door again. This will be working scapular depression. Back down. And again. Back down. We can also have our patient do resisted scapular retraction and protraction with the band. So again, back to the camera. For this one, back to the camera. For this one, I'll be holding the band. Patient's arms out in front. Just like the wall push-up, we'll have our patient go through retraction of the scapula, protraction. Keeping the shoulders depressed down as he does it, retract, protract. And again, and again. All right. In addition, we can go through resisted. In this case, we don't have 5-pound weights, but if we have 5-pound weights, we have our patient go through weighted abduction of the arms again. So straight up, all the way above them, watch the lamp, and back down. He can do this with 5-pound weights in his hand. You can also do plank position, scapular protraction and retraction on the ground. That'd be it.